Good evening, everyone. Thank you for joining us for tonight's In the Loop. We are going to have a presentation by Kendra Flores for a senior genetic or the senior genetic counselor from Christiana Care, and she's going to speak to us about hereditary cancers.
Meredith,
Kendra?
thank you so much for that introduction. I really appreciate you guys making the time to speak with me tonight. I love any opportunity to talk about hereditary cancer, but for this to be such an intimate opportunity to ask questions, update some of you guys, I really appreciate you taking the time out of your busy day. I want to first start off by sharing with you what's on my agenda, so you know what to expect. I want to review the nature of hereditary cancer, just define it again, just go over what it means to be a hereditary cancer versus just having a family history of cancer. I want to review who needs hereditary genetic counseling. So, as these guidelines change with time, I want to make sure that we're clear about who needs this testing and who might not need this testing. I want to discuss what's important to know about your family history. Even if you are here listening to me tonight and you have no history with breast cancer, no family history of breast cancer, if you were to speak with a friend about what you learned tonight, I would love for you to be able to share when someone is taking a good family history, what should be present in a good family history. And finally, I want to explore familial breast cancer, this new term. I wouldn't say a new term, but it's a newer area of exploration for this term. The idea that hereditary cancer has really been focused on quite a bit. And I want to make sure we give due diligence to familial breast cancer, which is an emerging area of attention. So, first, let's start with hereditary cancer, how that differs from sporadic and familial cancer. So, hereditary cancer has to be compared back to sporadic cancer. With sporadic cancer, which accounts for 65% of all cancers that we would treat at the Helen F. Graham, environment plays a much larger role than genetics does. So when I think sporadic cancers, I think of most lung cancers. Not all lung cancers are environmental, but a good number of them are. I think of many skin cancers, especially in areas that we know are exposed to the sun. And for many cancers, it could just simply be an occupational exposure or age that increase the likelihood of cancer happening in the first place. So, sporadic cancers are those where there is no strong family history, and we attribute those cancers to likely by fluke chance or exposure occurrence. Next, familial is this idea of the overlap between genes and environment. So, with familial cancer, we do see that cancer is clustering in a family. Perhaps there are more breast cancers than we'd expect by chance alone, but genetic testing will come back negative in this family because they can't be explained entirely by genetics, which is a good comparison to hereditary. With hereditary cancer, genes more or less explain the full family history. There's oftentimes one singular mutation in a one singular gene that can be attributed to the cause of the family history. For example, there could be a break in the BRCA1 gene that went from grandparent to parent to child to that child's child, and that is the culprit causing the cancer. I need to stress hereditary cancer is thankfully rare. My job is to hunt it out. That's why I'm a genetic counselor. But hereditary cancer is thankfully quite rare, and it only accounts for about 10% of all the cancers that we'll care for at the Helen F. Graham. When we think specifically about breast cancer, which one of those pie charts you fit into will make a big difference in ultimately what your lifetime risk of breast cancer is. So if I lay out this scale here at the bottom and we say, well, no one's really at 0% chance of cancer and no one's ever at 100% risk of cancer, where do people fall? Well, for most things, they fall on a bell curve. So the bell curve for the sporadic is about 10 to 12%. So the highest point in that bell curve is at about 10 to 12%, where that's where we quote most women, Jane Doe with no further information about her family history. We would quote her about a 10 to 12% chance to develop breast cancer in her lifetime. But simply having a grandma who had breast cancer, simply having an aunt who had breast cancer affects that woman's risk to develop breast cancer. Hence, the familial bell curve is a little bit wider, and that somewhat overlaps with the general population, as well as going up to 20s, 30% risk of breast cancer. You can have enough breast cancer in your family that your empiric risk to get breast cancer is in the 20s or 30%, even without a positive genetic test. That's the notion of if it's walking like a duck and it's quacking like a duck, We call it a duck. If you have a family history of breast cancer, we need to have breast cancer on the mind. But with hereditary, that's the step above familial. And once we call it hereditary, that means that we found the gene. That gene is what is causing the family history to be a higher risk. We have both moderate penetrance alleles and high penetrance alleles. So let me define that. Moderate or medium, these are the more ones that overlap with the familial bell curve. They're at a slightly higher risk in some cases, but they're more medium risk genes. The high penetrance genes, you guys may have heard of things like BRCA1 and BRCA2, to name drop two of them. Those are the ones where the risks are substantially higher in the range of 50 to 87%. And we, as you might imagine, would treat a person differently, or we would manage their risk of cancer differently if they were in the 20s versus the 50s to 80% risk of breast cancer. And by knowing what a woman's risk is, we can be more intentional about the types of screening we do and the intervals that we take between those screening regimens, or in the highest risk cases, offering women risk reducing surgeries to prevent the occurrence of cancer before it ever happens. So to simplify it even further, you guys get that things in the environment can lead to cancer. No one is going to get off this earth without being exposed to some things that might damage our DNA. But that damage that invariably will happen to our DNA gets corrected by things called tumor suppressor genes. So these, as their name implies, stop tumors from growing. So if, for example, the sun were to damage our skin and we were going to develop skin cancer, the UV rays damage the DNA, these corrective genes do something in our cells that stops that DNA damage from cascading into a tumor. And so because they're very important, we get one from our mom and one from our dad. And think about these as the two dukes we have up against cancer. You got your left and your right duke to fight cancer. You got your copy of that gene you got from your mom and the copy of that gene you got from your dad, and they're functioning to correct damage that occurs and stop a tumor from growing. Now, when cancer happens by time and exposure by chance, just like the wear and tear on the brakes in our car, over time wear and tear happens, and those protective genes can get damaged as well, and then they don't function as well at protecting cancer. And if perhaps in the same exact cell, the second gene also gets damaged, well, now you've got a cell that has no corrective protection action, and therefore it can progress onto a tumor. This is the sporadic cancer. This is that blue part of the pie chart. This is how most cancers happen. This sort of long-term acquiring of mutations to these protective genes that leave our cells without defense and put us at a higher risk of cancer. And when we lose it in two cells, the occurrence of cancer. Now, some people are born with one of those copies not working. Either that one they got from their mom or one they got from their dad has a mutation on it, meaning that the instructions are not reading correctly. That person is at a higher risk to get cancer because unlike everybody else who has two fists with which to fight cancer, one of those fists is tied behind their back. And as such, they don't have the typical amount of cancer protection, putting them at a higher chance that cancer will happen, as well as cancer happening at a younger age, because it takes less time for just one copy to break than for two copies to break. So when you have this one kind of shaded in, not working correctly, and that one gets damaged, well, that's a hereditary cancer. And you can imagine that's a bit more likely to occur. This gets me into the answer or the question of, well, then if this is out there, this occurrence of hereditary cancer, who needs to be assessed for this? Who really are we worried might have hereditary cancer? And it depends on who you ask. The easiest way to answer this question is, according to the American Society of Breast Surgeons, if you have personally had breast cancer, please come and meet me. My name is Kendra. I'd love to talk to you about your family history. The idea behind the American Society of Breast Surgeons guideline says all individuals, male or female, 20 years old, 90 years old, if you've had breast cancer, that's the ticket to entry. That by virtue of simply having had breast cancer, it's worthwhile investigating whether or not that could have been a hereditary cancer. That guideline came out in 2019, and it was very, very surprising when it came out because prior to that, we'd had a lot of pushback from insurances, not paying for testing and things like that beforehand. But with this American society, the societal guideline saying, you know what, the barrier to entry to genetic counseling and testing really needs to be lowered, it has done a great deal with making more and more insurances cover this testing. A main push for this new guideline to come out was that more and more so now, knowing your genetic cause, knowing the reason why you got cancer, makes a significant impact in how your providers take care of you for that cancer. Knowing which kind of surgery is the best surgery to do, knowing which chemotherapy is the best modality. Knowing why a cancer happened, the analogy I tend to say is if you know the cancer's weakness, then we can exploit its weakness. By knowing why a cancer happened, you give very valuable information to your care providers, which is why this guideline came along. But there is another guideline, and it's another guideline we still do use quite readily, and that's the National Comprehensive Cancer Network Guideline, or the NCCN. And NCCN currently says, yes, you ought to consider it for all individuals with breast cancer. But given that breast cancer is one of the most commonly occurring cancers in women in the United States, they provide additional guidelines for when it's recommended. And what's useful about the NCCN guidelines is we can use the American Breast Surgeons guidelines to offer it to everybody, but we can use the NCCN guidelines to dictate when is it more likely? What are the things that can show up in a family that make us more concerned that it might be a hereditary source? So because of that, I want to go in through a little bit of what those guidelines are. So this is the 2026 guidelines. And I know you're saying, oh, it's still 2025. They got super ahead of themselves. The 2026 guidelines dictate these reasons why you might really benefit from genetic testing and genetic counseling. This is a simplified or perhaps even an oversimplified list. It's not meant to replace full risk assessment. But if you have personally had breast cancer and you were diagnosed at or under the age of 50, that raises our suspicion. Because like I was saying, the younger a cancer is, or the younger a person is when cancer occurs, the more worried we are that might have been hereditary. Triple negative breast cancer. I'm sure this group is not unaware of triple negative breast cancer and how it's a unique different subtype of breast cancer that doesn't need estrogen, doesn't need progesterone to grow. And so therefore that unique subtype has a higher likelihood of being hereditary. Male breast cancer. So breast cancer in men is very rare in the general population. When it does occur in a man, we are more concerned of a hereditary cause. Multiple primary breast cancers. So this is really important to distinguish from breast cancer occurring and then recurring. Recurring is a fire being put out, but a few embers surviving the extinguish and then reigniting. That's a recurrence. Two primary breast cancers are two separate, distinct fires, one in one side of the breast, one on the other side of the breast, one in the left breast, one in the right breast. If we have reason to believe that these are two separated from one another primary breast cancers, that's like two lightning strikes, and it increases our suspicion that it might be hereditary. Simply having Ashkenazi or European Jewish ancestry also increases the likelihood that a person might have hereditary cancer. There are a handful of different mutations that happen with increased frequency in that population, and just by simply knowing you have that ancestry can raise my concern that you would have one of these syndromes. And finally, the blanket statement is if in your doctor's best clinical judgment, it would help them take care of you, they can recommend genetic testing and genetic counseling. So if it could make the difference between this or that surgery, or if it could make the difference between this or that chemotherapy drug, it can be very useful to know about. Now, some of you guys joining me today might not personally be cancer survivors. You might have a family history of breast cancer. So when we think about family history, we want to think about for both people that have had breast cancer and have a family history of these other cancers. Or if you simply have a family history, if you yourself have not ever had cancer, what are the things that you might see in a family history that would raise suspicion of a hereditary cause? Three or more, and it can be a mix of breast and prostate cancer. So that can be two breasts and a prostate, or two prostates and a breast, but three all on the same side of the family. So it can't be a paternal aunt and a maternal aunt. It has to be three all on the same side of the family. So it could be your sister, your mom, and your mom's sister, as long as all those people are blood related to one another. Two or more, again, breast or prostate cancers, as long as one of those two was diagnosed under the age of 50, again, just like with the previous slide, this idea that the younger the cancer is, the lower the barrier to entry. Having a close relative, and that's defined as something as far out as a grandparent or a cousin, with ovarian cancer, pancreatic cancer, breast cancer in a male, or when someone else in your family has tested positive. So what you're seeing here with ovarian, pancreatic, and male breast cancers, those are all examples of relatively rare cancers. Those don't occur commonly in family histories. So when someone reports to me that they have a family history of pancreatic cancer, a family history of ovarian cancer, it makes me more suspicious about why that happened. And again, it's very important when we're talking about ovarian, pancreatic, male breast cancer, it's making sure that we're sure about those diagnoses, because a lot of times it's very difficult to know exactly where a cancer started. This last bullet of when another family member has tested positive for a mutation really leads me into this idea of taking a good family history. So imagine there's you got your glasses and your curly hair, and you of course are going to be thinking about your children first. I almost always our minds as women tends to go like directly down the lineage. Are there kids, daughters perhaps, that might benefit from this information? Your brothers and sisters, and then their kids, your nieces and nephews. Even if these are estranged siblings, they do still increase they still matter, they still count. Of course, you want to think about both your mom and your dad, their siblings, your aunts and uncles, their kids, your cousins, and of course, your grandparents on either side. So in a genetic counseling session, we take this complicated people, these people that you know which ones you get along with and which ones you don't, which ones are, living close by and you would know if they had cancer, and which ones you haven't seen since you were young and you don't know what's going on with them. All of that complexity and all that nuance that you understand, and we turned it into this, a pedigree. Women are circles, men are squares. Women are always on the right because women are always right. The general idea here is that we're trying to take the full information that you have and map it out and sort of suss out what is the actual likelihood of finding a mutation, and what do I see? What connections can I make? What things concern me? And also what reassures me? Keeping in mind that I know there's going to be unknowns. I expect that there's going to be unknowns. Even the most well communicating family histories still include unknowns. We are at the whim of what people are willing to tell us. So when we take these family histories, we try to get at what kind of cancers are there, what can we do about that? So when trying to inform a good family history, what would I recommend you gather? First, who had cancer? And this is oftentimes one of those things when we're going even more distantly to ourselves, getting that, talking to that sometimes parents, sometimes siblings. How are they related to you? Are they your first cousin? Are they first cousin once removed? Perhaps it might just be better to get to the bottom of, how trace the line. It's grandma's sister's child versus grandma's brother's child. What side of the family? Map out who they are to you, and we'll figure out how related to you they are. What type of cancer was it? And as you guys may very well know, we tend to name cancers from where they start, but a lot of times when families are telling the lore of what happened, they tend to describe it based on which cancer took the person's life. So, for example, I'll hear a lot of people saying, oh, that person had bone cancer or that person had lung cancer. And I always want to make sure that I'm clear. When you say lung cancer, did it start in the lungs? Or did, say, a breast cancer spread to the lungs? Or did a breast cancer spread to the bone? Because those are common places where breast cancer will spread. And it's important to differentiate lung cancer that started in the lung and is not particularly hereditary versus breast cancer that by chance happened to spread to the lung, but still is concerning because it was breast cancer in origin. So, as much as you're able to, the people to talk to who might know a better answer, not only what kind of cancer was it, but where did it start? And if you are unable to get to that, that is okay. Simply saying they think it was abdominal, they think it was gynecological, they think that it started here, but they aren't exactly sure. In many cases, we may not even in medicine be able to tell. How old was this relative when the cancer was found? So, a lot of times people will tell me how old a person was when they passed away, which is helpful to know. But what matters a lot is how old was he or she when they got the diagnosis. Even if the person fought it for many, many years, knowing did that diagnosis occur, oftentimes the important thing to know is under the line in the sand that we drew at 50. We had to draw the line somewhere between old and young, and they called anything under the age of 50 as higher likelihood of being hereditary, a younger cancer. So knowing in your best estimate guess that that cancer was diagnosed under the age of 50 can really impact the likelihood that what we're looking at could be hereditary. And finally, has a person in the family who, especially those that have had cancer themselves, undergone genetic testing already? And if so, can you obtain a copy of their results? So when a person gets genetic testing through me, I always provide them a copy of those results, and I encourage them to keep them in a safe place in their home. Oftentimes, where you keep birth certificates, keep them in a safe place. But to also be willing and able to share that information with their family members, because you'd be surprised how often just sharing the knowledge that you've done genetic testing can prompt family members to say, oh, I also did genetic testing. Let's compare our results. Genetic testing really should never be interpreted in a vacuum. It really is meant to be interpreted in the context of the larger family. So knowing that someone is negative means something differently than if they're negative, but another relative was positive. Let me explain further. This gets at the crux of informative testing. So imagine this is that pedigree I started drawing you out to here. Imagine this is you, and you're coming to me because your mom had breast cancer back when she was 48 years old. And like I said, any breast cancer under the age of 50 is concerning to possibly be hereditary. And you come in because you have a young baby, and you're full of motivation to make sure you saw what your mom went through. You don't want to go through it yourself. You want to be proactive. And I love that. As long as mom is around, if she is available, alive, and testable, I always will inquire what is the likelihood that you could talk to mom and see if mom would do this testing. You might ask the question, but I'm here and I brought my blood. Why not just test me? And let me explain. If I have mom in front of me, mom who has had breast cancer, I will throw the books at it. In other words, if there could be a possible cause, we want to test all the possible books in the encyclopedia set of how to fight cancer. We want to read all the books. And in some of these tests, we're talking 40, 50 genes. And imagine each gene is a book with thousands of pages that we're reading looking for a spelling error. And if I do that great big extensive test in your mom who has had breast cancer, and I find a spelling error in the fifth book on the 3,566 page, it will be just as you're seeing in this picture here. I will know that's the word that's spelled wrong, and that's the specific mutation in your family, so I can be certain I didn't miss it. In other words, if you were being asked by a friend to read their letter and check for errors, or to read your child's essay and check for typos, if you knew what word was spelled wrong, you are far more likely to catch that typo. The same thing with genetics. If we're armed with the knowledge of what the culprit is, we can be sure not to miss it in someone's testing. Further, if I know why your mom got breast cancer and you test negative, I know I tested for the right thing. I can rest assured that you dodged it, that the cause of the family history did not get to you. Whereas if mom never does testing, then I can rest assured that you didn't have a mutation. But was there a mutation to find in the first place? We may never know. So by testing a person who has had cancer first, we do our best at trying to get to the bottom of, is there something to find here? Will genetic testing be fruitful in the family? So I'm realistic. I live in today's world. I know family doesn't always keep in touch. I wish I kept in better touch with my family. And I feel like, it's a conversation that ought to happen, but I'm realistic and I recognize that some people don't live in the country. Some people don't have health insurance right now. Some people are long gone and we cannot test them, and I get that. So if the conversation to test an affected relative is there, we should have that conversation. But above all, if you meet any of those criteria that I discussed, you would very much benefit from considering genetic counseling. So what does a genetic counselor do? I'm not a doctor. I don't play one on TV. The general idea is my goal is to establish what your goals are and help meet those goals. So when I say establish an agenda, this is oftentimes a genetic counseling session is the first time that you are going to have 60 minutes of uninterrupted provider face to face to discuss your family history, what concerns you have with your family history, taking a far more detailed family history than you normally do in an appointment. We're going to review what I was able to glean from your chart. So in reviewing for your appointment, what did I see in your medical record? What questions do I have? Did I get anything incorrect here? Which breast was it? What's the staging? Do you have a surgery date? Things like that. I'll take that family history in as much detail as you're able to provide, including the very acceptable answer of, we're not sure. I don't know. Maybe I could get back to you. Then I'll do my best to do what's called a risk assessment, where I take that family tree and I try to tell you, am I looking at a 2%, a 10%, a 20% chance that testing like this will come back positive if you do it? Then we'll talk about the genetic testing itself, how it's done, when to expect it back, how we're going to get it paid for by your insurance, including a very in-depth conversation about how it could benefit you and your family, what risks are inherent with doing genetic testing, as well as what testing can tell you and what it can't tell you. You know, it's not a crystal ball. It can tell us lots of valuable things, but we have to know that even the most up-to-date technologically advanced genetic test cannot predict the future. Finally, I promote informed decision making. What that means is I don't tell you what to do. I tell my husband what to do. I tell my kids what to do, but I don't tell my patients what to do. I try really hard to meet you where you are. What is your value system? What's important to you? What would make doing this testing worth it? What are your reservations about doing this testing? And help make sure that whatever you decide to do is beneficial for you and your family. So what if I've already had genetic counseling and testing done previously? Does that mean that I might need more genetic testing in the future? And the answer is perhaps. It is really important to check in with genetic counseling, genetic services periodically. And so I'm very thankful to have been at Christiana Care for now almost 10 years now. So anybody that's my previous patient is more than welcome to drop me a line. I'm also very happy to see you if one of my former colleagues was your genetic counselor, and I'd love to adopt you into my group. The idea here is that it's a really good idea for you to touch base with the genetic services every couple of years because of two main things. On one hand of the equation, your medical history might have changed. Your family history might have changed. So when I mean medical history, you got a colonoscopy and there was far more polyps than we thought. Family history, what if another cousin got diagnosed with cancer? That's important to tell me. Has anybody else in the family gotten genetic testing? Maybe you had a genetic test, but it surprised you that your aunt came back positive. That's something you need to update me about. On the other hand, what's stuff that I could update you about? Well, have more genes been discovered? If you had a gene test that had 25 genes and now we're offering 48 genes, you might want to consider updating to that larger version of the panel. Has the technology that we do this testing improved? So some people have had testing done where it would have missed areas of the BRCA1 and BRCA2 gene. And it's important to make sure that they're getting the testing done on the newest version, right? If we're getting a new iPhone every year, we should really be assessing was our genetic testing done on the rest technology as well. Finally, if you had ambiguous results, or if you had results where we were looking to see if other people would get testing and help interpret what those results mean, as time goes on, our understanding of these genes, our understanding about what's harmful and what's harmless, improves and grows with time. So it's always a really good idea to be pen pals with your genetic counselor. Every couple of years, drop him or her a line, update them on the family history and what's changed in the last 2 or 3 years. And in turn, they will update you on, is there a reason to come back in for more testing? Do they have residual questions? And invite you back in for another appointment if there's something substantial to offer you. So you teased this idea of the importance of this new emerging data on familial genetic testing and familial cancer. What about the people that are in the red part of the pie chart? So again, just to define, if you have a family history or you have personally had breast cancer and genetic testing has failed to provide a diagnosis of hereditary cancer, meaning that the test was negative, it wasn't positive, but you still have more family history of breast cancer than we'd like to attribute by chance alone, then you might have familial breast cancer, which is, sure, the test didn't work, but still, that's a lot more breast cancer than we can attribute to chance alone. And to understand familial breast cancer, I use this chart. So let me orient you to this. Up here at the top, these are genes that you may have heard of by name. BRCA1 and BRCA2, I've name dropped those a couple times here tonight. TP53, very high risk gene, but thankfully very, very rarely mutated. Other genes that you might see here are all relatively rare, but have relatively high risk of cancer. These are the more medium risk genes. They're occurring perhaps more frequently in the population, but they confer a lower risk of cancer respectively. In general, the higher the risk of cancer, the less frequently we see mutations in that gene. We know, however, here represented by a bunch of dots, are a bunch of other genes that we would never know by name. I would not ever tell you the names of all of these because each gene individually having a difference in them isn't a mutation. In fact, we call them SNPs, single nucleotide polymorphisms. Why are they called SNPs? Because differences in them are not consequential enough to be called mutations. In other words, these are variations that if we looked at a group of women that all got breast cancer, and we looked at a group of women that all got into their 90s and never got breast cancer, you'd find these SNPs more often in the group of women that got breast cancer and less so in the group of women that did not get breast cancer. It's not saying they're causative. It's not saying that those cause an increased risk of breast cancer, but used collectively, we believe that there are individual differences, individual markers, so to speak, that occur more often in family histories with breast cancer than in family histories that don't have breast cancer. These SNPs account for what this genetic testing here cannot explain. For example, if you think of these dots as nameless markers that increase risk, and you and the neighborhood family that grew up next to you all had the same exposure to a chemical in the well water, and your family had a bunch of cancer, but the family that lived across the street and shared the same well water did not have cancer, perhaps the difference in the rate of cancer can be explained by your family having 10 of these markers, 10 of these dots, where the family across the street only had 1 or 2 of these dots. The dots weren't to blame. It was still the chemicals in the well water in this hypothetical situation. But our tolerance of the environment, our ability to tolerate estrogens, our ability to tolerate pollutants and UV rays and chemicals and radiation are different based on our relative markers. And that is where we get into familial. So almost everybody that I encounter has heard about Angelina Jolie back when, oh gosh, it was like 2011 or so, when she came out and she said she was a BRCA carrier, and she did an amazing amount of work to raise awareness for hereditary genetic testing and the existence of hereditary genetic testing. And because of her willingness to put herself out there, which I think was enormously brave, we have far more people aware of BRCA1 and BRCA2, aware of the ability to do genetic testing, and she's done us a great service by doing this. Less so, people might not be aware of this woman. Her name is Olivia Munn, and she is a famous actress also, just like Angelina Jolie. And she's been in the news a lot recently because of her own experience with breast cancer, but she's doing a really great thing by raising awareness to the red part of this pie chart here, the familial component. So I'm going to read from you an excerpt that is from People magazine and a quote from her Instagram. In February of 2023, in an effort to be proactive about my health, I took a genetic test that checks you for 90 different cancer genes, she began. I tested negative for all, including BRCA, the most well-known breast cancer gene. My sister Sarah had just tested negative as well. We called each other and high-fived over the phone. That same winter, I also had a normal mammogram. 2 months later, I was diagnosed with breast cancer, she continued. In the past 10 months, I have had 4 surgeries, so many days spent in bed, I can't even count, and I have learned more about cancer, cancer treatment, and hormones than I ever could have imagined. So what Olivia Munn did was raised awareness to the idea that many people who've had cancer don't have their family histories of cancer explained discreetly by a genetic test. And it raises awareness for the fact that there are holes in what genetic testing can cover and what it can't cover, and we need to do a lot to fill in that gap. In fact, even since she came public with this in 2023, she was later in the news again because her mother, inspired by what her daughter went through, also got assessed, was deemed high risk, and also was subsequently found to have breast cancer that would have been missed had she not gotten breast MRIs. Enter the Tyrer-Cuzick model. So the Tyrer-Cuzick model is something that I want to raise as much awareness for as I can. So you guys remember this scale here where I said no one's at 0, no one's at 100, but I referenced this bell curve here, the red bell curve for familial. And that's a pretty wide bell curve. And how you might think of your risk if you were at, say, 15 versus if you were at 35 might be very different. Well, how does a woman figure out, is she at 15 or is she at 35? The Tyrer-Cuzick can help. The Tyrer-Cuzick is just a computer program. And what it does is it looks at data of women that have had cancer versus women that have not had cancer. What factors are in common among the women that have had breast cancer from the women that have not had breast cancer, and turns it into an algorithm to calculate a person's risk to get breast cancer. It's so sophisticated that it can take into account things that would raise or lower it, not based only on family history, but unique criteria about that woman. Here's a picture of the tools we use to run a Tyrer-Cuzick. So for example, how old is the woman? You might think, okay, well, the older the woman is, the higher the remaining lifetime risk would be, but it's not that way. The younger we are when we do the assessment, the higher the assumption is that you might have 40, 50, maybe 60 more years ahead of you, hopefully, with which to get breast cancer. So we will take that calculation and say, oh, this woman's only in her 30s. I hope she has a good 60 years ahead of her. It'll keep in mind menarche, meaning when you had your first period, how tall you are, height and weight. How old were you when you had your first baby? Have you ever had a biopsy in the past? When did you go through menopause? Are you currently going through menopause? If you've been through menopause, did you use hormone replacement therapy in any way afterwards? It'll ask you mammographic density, which is an important thing for us to raise awareness about. Mammographic density is something that you can only tell using a mammogram, but is something that can really impact, especially as we age, our relative risk to develop breast cancer. And then it will take a family history. And as you answer these questions here, it'll build a nice little family tree here on the side. It can include things like half siblings, cousins. It's very sophisticated. And in fact, it doesn't just say how many women in your family have had cancer. It says how many women of how many women. So you can imagine if your one aunt of one aunt had breast cancer versus your one aunt of 7 aunts had breast cancer, your risk would be different. And this program can tell the difference. It uses your answers to all these questions to populate what your remaining lifetime risk of breast cancer is. And what's useful is almost all insurances will see a Tyrer-Cuzick or a TC of 20% or higher as justification for paying for breast MRIs. So if you have a Tyrer-Cuzick of 20% or higher, in addition to routine mammogram, like all women over the age of 40 should be considering, a woman is also offered breast MRI. Breast MRI is particularly useful for women that have dense breast, and especially for women that have dense breast and a significant risk of breast cancer. And when a woman qualifies for both of these images, ideally we would try to space these out where one is one you do on one side of the calendar and the other image is the one you do on the other side of the calendar. So let's say October, Breast Cancer Awareness Month, that's always your mammogram time. But because you're a fall mammogram, we're going to make you a spring MRI. And so every 6 months, you're getting one image or the other. So you're really never going more than 6 months between some sort of image of your breast. These two different images are meant to complement one another. So they're able to catch things that one alone would miss. The goal here is if cancer were to happen, and we hope sincerely that it doesn't, but if you're assessed as being higher risk, that we catch that cancer early when it's much more treatable. The Tyrer-Cuzick cannot be done on someone who has personally had breast cancer, but it is absolutely something that should be asked for. You should be the squeaky wheel that asks for the grease if you have a family history of breast cancer and thus far genetic testing has failed to provide an answer. Olivia Munn shares the experience that her Tyrer-Cuzick was above 20. It earned her breast MRIs, and it was only through the breast MRI that she was able to find out that she had breast cancer. So with that, that is my presentation. I want to absolutely take time to answer your questions. I really appreciate your time and attention. I hope this conversation raised questions. But if the question that you want to ask is one that's private in nature, I do want to share this is my direct email. So if the question that you want to ask me is one that you're not comfortable with me answering with the group, please do feel comfortable to email me directly.